All right, we are going to go ahead and get started. Hi, everyone. Before we start, I want to give a special thank you to those of you who were on last week's canceled webinar. We really appreciate all of you for hanging in there with us and apologize again for our technical problems. So that being said, thanks to everyone who is joining us today. Today's webinar is Partnership and Collaboration, Bridging the Gap Between Treatment Services and Advocacy, the third of our new webinar series for substance abuse counselors and other allied behavioral health professionals working with women. Our trainer today will be Patti Bland, MA, CDP, and Director of Substance Abuse Training and Technical Assistance for the National Center on Domestic Violence, Trauma, and Mental Health. Before we get started, I want to go over some of the technical details of the WebEx software that we'll be using for today's webinar. Many of these details are also explained in the Using this WebEx System tab in the upper left-hand side of your screen. Please be aware that your screen might look a little bit different depending on whether or not you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have any questions regarding the training content. You can also contact Jennifer Curley, also with the center, if you have any questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants if you'd like to respond to a question from the trainer or contact me anytime during the session. You should click on Jennifer Curley to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go into the chat box, click on all participants, and type in what field you work in, such as domestic violence, substance abuse, the legal system, etc., and press enter. This way we can test the chat function and also get a sense of the different kinds of work folks are doing right now. All right, we've got a couple of domestic violence folks, education. Great. Folks can continue to share in there the kind of work that they're doing, and I really appreciate you helping us out with that. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel a little bit distracting. And if this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you don't want to see the captions, you can click on the down-facing arrow next to the word media viewer the same way you might if you want to hide the chat box. At the end of the evaluation, at the end of the webinar, you'll be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, you can return to the original email that you received and click on the link to re-enter the training. If you're experiencing technical difficulties and are unable to contact Jennifer Curley, you can call WebEx Tech Support to resolve any issues. That phone number is 1-866-229-3239, and we will also post this in the chat box. Thank you all for joining us today, and I will now turn the training over to Patti.
Hi, everybody. Thanks again for hanging in there, and hopefully we will get through this webinar today without a glitch. We will be talking about partnership and collaboration, and primarily the issues we'll be discussing will be the similarities and differences, as well as tools and strategies to support collaboration, primarily between people working in the substance abuse sector, as well as the domestic violence sector and sexual assault sector, and of course the allied professionals. So with that said, let's see if I can get the thing to work. I'm always a little pokey here. All right, let's see. Of course, I'm having trouble today. Oh, dear. Bear with me. I got it, finally. Thank you. So before we start, I just want to remind that even though today's webinar is primarily process-oriented, whenever there's discussion involving domestic violence, sexual assault, and substance abuse or other forms of oppression, it could bring up unexpected feelings and responses. So if you feel overwhelmed at any time, we encourage you just to turn the volume down or take a break, and be sure, if additional help is needed, to debrief with a trusted individual. And we do have follow-up technical assistance relevant to this webinar available in a variety of formats and resources if they are needed. So hopefully all will go well today, and I wanted to remind you that whenever we are talking about substance use and substance abuse coercion and collaboration with domestic violence and sexual assault programs, we tend to be looking at it through the human rights and social justice lens, as well as the cultural and community lens, domestic violence advocacy lens, and then that trauma-informed lens. Our approach is survivor-defined or person in recovery-defined. We work very hard to ensure physical and emotional safety and to incorporate hope and resilience and relationship and connection into all the work that we do. And here we go. I won't bother with the goals and objectives. I think it's pretty clear we're talking about how to do a better job with collaboration and to look at the differences between the fields and the similarities. So one of the things I was thinking about, and this is probably, for those of you that know me, and by the way, hi to Shirley there in Juneau. Nice to see somebody from home on the webinar. For those of you that know me or worked with me in the past, you know that I started out as a substance abuse professional and switched into working in the domestic violence and sexual assault arena. And it was really interesting to me at the time. It was actually really challenging because I had started out in substance abuse, and when I found myself in a domestic violence program, I felt like I landed on the moon or something, because the way the fields are organized on the surface, you would think that they're completely different, but once you begin to straddle both sectors and understand the roots of the fields, you find out how similar they are. But really, the goal of advocacy and the goal of treatment are considerably different. So, of course, I ran into the dictionary to kind of begin to talk. Certainly people in the legal arena are well aware, as well as advocates, that when we use that word advocate, basically we are saying one who pleads in favor of a position or a person. So someone who is for someone. And that means it's you're for that person, and you are actually advocating or supporting a cause or a proposal or whatever it is that person needs or wants, basically, when you're talking about being an advocate or advocacy. And when you look at, and it's not clinical, actually, when you're talking about advocate and advocacy, you're not talking about clinical skills. You're primarily talking about providing a voice for someone. And when you are looking at treatment and treatment providers, really when we're describing a treatment provider, the basic definition would be one who helps in identifying or preventing or treating illness or disability. So that is what treatment involves. And treatment itself is actually a generic, non-specific term for health care, which is intended to relieve illness, injury, mental health problems, etc. So it's much more clinical in nature. And so right there, I would say when you think of the early problems for battered women and survivors of sexual assault, one of the things that survivors stressed and their advocates felt was true, that by having that experience of domestic violence or sexual assault, systems tended to let survivors down by frequently looking at that activity as some type of mental health concern or pathologizing and putting a label on the survivor as if there was something wrong with them, or that they were, quote, ill or sick or something along those lines, just by virtue of having experienced the crime or having experienced the harm. And so the field has worked really long and hard to prevent that, quote, medicalization. If you look at the alcohol drug field, what you know is that the stigma associated with recovery is not unlike the stigma that people that experience domestic violence or sexual assault experience. But the thing with substance abuse and alcohol addiction is that the stigma associated that there is blame. I'd say you would certainly say that in domestic violence and sexual assault, but people were often labeled with really negative terms, which I won't get into right now, but usually it was bad this, bad that, bad mother, bad, I won't go on and on. And when you talk to people that worked in the early days in the recovery movement, they worked very hard to find a way that people could escape the labeling that was associated with substance abuse and substance use disorders. And so when they were able to get these problems identified as medical concern and recognized as an illness that was chronic, progressive, and lethal. I've had probably hundreds of women in recovery over the years tell me, I'd much rather have someone treat an illness than call me a slut and a whore, those kinds of comments. So these are things you want to be aware of. But for advocates and advocacy, the field has worked hard to prevent any kind of clinical labeling, and for substance abuse treatment, actually having a clinical label was perceived as a plus. So they could see that there's some differences, but they're rooted in similar thinking, okay? And the one thing that I could tell you about being an advocate is that there's really nothing neutral about it. There are certain beliefs that many advocates hold. I can't speak for all advocates, but in general, over the years, I have found the following opinions and beliefs to be fairly consistent in many, many domestic violence and sexual assault agencies. And so when advocates talk about who they are and what it is that they do and what they're for, they tend to stress that they are for basic human rights and that they are against domestic violence, sexual assault, and all forms of oppression. Anti-oppression work is frequently critical and a key component of most mission statements in domestic violence and sexual assault programs. The advocates are not neutral. They're for the people they serve. Where they get their expertise is from, and have been doing since the 70s and before. Advocates actually bear witness to people's inhumanity towards each other and their children. They listen to the stories. This is what they do. They listen. And they hold those who harm and abuse others accountable for their actions. And they're against any form of victim blaming. And they I think that when I say they, I should say we. I worked in a domestic violence program from 89 until 2001, and then I worked in the domestic violence and sexual assault arena from 2001 until 2012 when I joined the center. So advocates tend to really want to make sure that the people they're serving are not blamed for their actions, and the experience of advocates is valid. And it is also a form of knowledge that's often overlooked by researchers. I remember when I went to do some training at Providence Hospital in Seattle, the docs had asked me, can you tell me how much domestic violence is occurring? And this would have been, like, I'm talking back in the late 80s or the 90s, early 90s. And I remember saying, oh, I'm not sure in the number, but there's a lot of it. So you can imagine that wasn't perceived as particularly knowledgeable and research-based at everything. And what that comment, oh, well, I think there's a lot of it, what that led to was the hospital system actually choosing to survey their patients and find out how much domestic violence was going on. And shockingly, they found out that well over 50% of their patients had experienced lifetime problems with domestic violence, and that close to a quarter were currently experiencing physical assault. So they got the data they needed, and so that's an example of some of the differences, but also some of the pluses of working with multiple systems to identify the scope of the problem and how big it really is. So treatment providers, I worked as an alcohol drug counselor. I started doing that work in the early 80s and continue to do so to this day. And as a treatment provider, I, like many of my colleagues, hold strong beliefs too on these issues. And over the years, again, I can't speak for all alcohol and other drug professionals or behavioral health providers, but I can tell you in general, when you talk to many people in this field, a commonly held belief is that providers are for treatment for those who need it. And I think in an ideal world, most substance abuse professionals would like treatment to be on demand if possible. They are against what in the alcohol drug field we call addict phobia, which would be similar to heterosexism or any other kind of ism or ableism. It's when a person is looked at as a scary, frightening, inhuman creature by virtue of the experience of addiction. And so we in the substance abuse field would consider this a form of ableism and also oppressive. I would say that providers are for improved health and well-being for the people they serve and for their families, that they too bear witness. They bear witness to the damaged substance abuse levels against adults and their children. I believe that providers hold those who experience a substance use disorder accountable for their behavior under the influence, but they are against blaming a person for actually experiencing a substance use disorder. Anyone might experience it. Just as you don't know until you go out with someone or have that first date, you don't know whether or not that person that you've gone out with is going to be abusive. You don't know until, you don't know when the doc gives you a prescription or when you have that first glass of wine with dinner, or you don't know that it could possibly lead to a significant long-term chronic health problem that could be lethal. And I would say to you that providers, substance abuse treatment providers, their experience is valid, and also what they learn on the ground is a knowledge that often is too overlooked by some researchers. So these are some elements, and when you listen to the elements of the beliefs, there are many things on either side of the street that both groups, both advocates and treatment providers, may actually experience in common. They're not that different in many ways. Okay. So I want to share with you what I've learned over the years from talking to substance abuse professionals and alcohol drug professionals, behavioral health professionals, and also with domestic violence and sexual assault advocates in terms of priorities, goals, values, and challenges that we face in our respective fields. And so as we move forward, I would tell you that, again, these are not universal in all cases, but in general, if you're talking to advocates, these are common concepts and they're values that are familiar to advocates. And it's useful for our people that are working in other fields to be aware of this. So when we look at safety, for example, if you're working from an advocacy perspective, whether we're talking about domestic violence or sexual assault, safety is perceived as more than just a physical place. Okay, so it's more a state of mind, how I'm feeling at any given moment. Just being in a shelter or being on a crisis line or being in a sexual assault support group doesn't mean that I necessarily feel safe in the moment. So safety is more than a physical place, and freedom of choice may actually be more important than safety. And this is another hard concept to wrap your head around sometimes. Certainly if anyone's worked with Adult Protective Services, I know in Alaska, if you were to get over to the Adult Protective Services webpage, they have a big, large sign that says freedom, that autonomy is as important as safety. So being able to choose how you regulate your day, how you go forward, what you do without someone controlling you may be worth risk. And this is often difficult for people in other fields to understand, because sometimes in other fields the focus is on immediate physical safety at this moment in time, and why don't you leave, why don't you do this, why don't you do that, rather than on determining and exploring what it is the person needs and what freedom of choice they want to be able to engage in, as opposed to being told what to do. If you tell people what to do in the domestic violence sexual assault sector, what they're experiencing is traumatic in many cases and highly reminiscent of being told what to do by a person who hurt them, whether the hurting was through domestic violence or through sexual assault or sexual abuse. The other thing that is fairly common and value that is familiar to many, if not most advocates is that the work is provided and done within a feminist perspective. And just to recap what that means, it's not about burning bras and all that kind of stuff. What we're talking about when we say feminist perspective is, again, a recapping of that advocates are generally against any form of oppression, and that programming, when you're talking about a domestic violence program or a sexual assault program, is generally rooted in the experience of survivors of sexual assault and domestic violence and their advocates, as well as feminist research. And when we're talking about feminist research, just to keep it simple, I would say that along with valuing hard data and numbers, also research that includes a narrative and that where you get to hear stories and incorporate them, and where you get to ask what questions need to be asked, as opposed to having someone who doesn't understand domestic violence and sexual assault coming up with the parameters of the research. That would be what feminist research is, where the questions are asked that truly reflect the experience people have when they are being harmed by a person that they love and care for that is hurting them, or a stranger when we're talking about sexual assault. Although I would say the majority of sexual assaults are done by people well known to an individual who is hurt. Okay, so I think when we look at domestic violence and sexual assault service priorities, when you look at how we're rooted and how we began in our work, a lot of the work revolved around being responsive and providing a crisis line service where someone can call. More recently, sexual assault response teams have become an element, where people are supported interdisciplinarily following a sexual assault. And the other thing that I want to stress is that a major element of domestic violence and sexual assault service priorities is legal advocacy and other system advocacy. And you never want to forget that if you're working with domestic violence, sexual assault advocates. I know from talking to Christine Pate from SITCA, she's with the Alaska Network on Domestic Violence and Sexual Assault Legal Advocacy Project's Pro Bono project, and she says it over and over again, when people are asked, when survivors are asked what their #1 priority is, the majority of survivors stress access to civil legal resources. This is a critical issue and very important for people wanting to work with us to understand. Children's services have been incorporated into domestic violence and sexual assault work, sexual abuse work since the beginning. And again, in recent years, I should say the last 20 or so, maybe a little longer, there's been a bigger focus on community-based sexual assault and domestic violence programs and services that are non-residential as well as residential. Shelter and transitional housing programs are still key elements that we're tasked to provide as a major portion of our services, I should say. And both domestic violence and sexual assault advocates tend to provide support groups, one-to-one support, safety planning, and I don't have it written here, but I would say, again, legal advocacy. Those are key elements. Anyone have any questions or comments? Okay, if you think of something later, just let us know. I'm going to move forward and talk to you now about some of the common concepts or values that are familiar for people providing substance abuse treatment. And so when we're looking at behavioral health and substance abuse treatment providers, when they're talking about sobriety, there's a distinct difference. What sobriety means, it is much more than merely being abstinent. So if you're talking to people from the recovery field, they think of sobriety as a gift to yourself, as a process, as something to strive for. And it is more than abstinence. And through the choice of sobriety, the treatment providers have come to believe and have learned from the people they serve that structure can actually be more empowering than complete freedom. So structure can be really helpful. And when I'm talking to you about structure, I'm not saying arbitrary, capricious rules and guidelines and things that are overly demanding, but structure that is agreed upon between the provider and the service recipient who is getting support and who is clearly informed about what to expect and what is needed based on their life, ASAM criteria, a whole list of things. So empowerment may actually be accompanied by structure if you're looking at treatment. And again, recovery is a process. You don't get recovered in a moment. People often say, well, gee, if you went through treatment, aren't you cured? And it makes about as much sense as like, well, if you went to shelter, aren't you done? Because we know that when you go to shelter, you could be at greater risk that leaving causes more significant risk for lethality and harm. And a recovery is the same. When you stop using, it can be very challenging. It can be very difficult. And as with battered or abusive person, they could be tracking, stalking, monitoring you coming in and out of your life. And if you have children, you may be dealing with them for the rest of your life one way or another. And for me, when I think about people who are seeking to gain and maintain recovery, I find from those who experience a substance use disorder that they often describe their experience like having an allergy. They do pretty good, but if they unexpectedly find themselves with a substance, or I was talking to someone who told me they got on Alaska Airlines and asked for a tomato juice, a spicy tomato juice, and it came, but the flight attendant added a shot of vodka. That could have been lethal for that individual who was in recovery. So, you know, that could have undone everything or set that person off on a path they had no intention of going. Or if you've talked to people in recovery, maybe a person has cardiac problems and has to have surgery and they have to take pain meds. This kind of thing can interrupt that recovery. So a lot of survivors of substance use disorders tell me they think of it as an allergy and they think of it as deadly, and they need to have skills that stick with them lifelong to deal with the daily challenges associated with this process. Other things that, one of the things I want to mention too is that when we're talking about sobriety as more than abstinence and recovery as a process, when we talk about various strategies, not everyone decides to seek recovery or go and get abstinent. There are numerous harm reduction models that are available to keep a person alive long enough in case they do decide to go forward with recovery, or at least to carry on as best they can within the limitations of an illness. So harm reduction strategies might be the use of methadone. They may be safe housing, housing first models. They may be needle exchange programs. They may be things that will keep that person going long enough and where they can feel like they want to take the next steps or choose not to. That's their decision. Concepts also include the notion of confidentiality. I'd say this is true for domestic violence and sexual assault advocates and as well. But that notion, the federal statutes, just as they are under OVW for domestic violence, are very stringent, as well as state rules and requirements. But confidentiality is highly valued. And another concept that is certainly not common everywhere, but if you're talking about people that were trained years ago or who participate in self-help model, such as Alcoholics Anonymous or NA or things like that, this notion of self will run riot. And this is where you see a difference in thinking between the domestic violence field and the substance abuse field. Because in domestic violence, we are really, really strong about free will, do what you need to do, you get to decide. And in the substance abuse field, the general thinking, again, it's just the attitude that many advocates, or sorry, many substance abuse providers have, not all, but many, is that your thinking and your ability, your choices have got you where you are, so you now need to do something different. So this kind of concept of let us help you because your own decisions have caused you great grief is considerably different than what one experiences in many domestic violence and sexual assault programs. And with that said, certainly not everyone in the alcohol drug field holds that philosophy, but it's not uncommon. Another highly valued quality in substance abuse treatment is honesty. And so people are generally and often advised that keeping secrets and not sharing what is happening and not being straight up about what you're doing has made it possible for you to hide and continue drinking and using and get into trouble. And so a lot of programs and certainly peer models will stress honesty. And this is I think this is really interesting too, because when in many cases in domestic violence, it's not safe to tell the truth. And we often understand that a person, like for example, if someone is queried, are you experiencing domestic violence, the person may deny it. If they're not in denial, they may not feel safe. They may not feel they can reveal it. And the same is true in treatment. People may not feel that they can reveal it, but they're really encouraged to be as honest as possible. And so it's one of those differences. Often think about it because, when I worked in shelter, I used to work the night shift in Seattle for about 12 years on the night shift. And at that time early, now the program that I work with screens in rather than out. But when I first began doing the work, we used to ask people when they called if they were using alcohol or other drugs or had or whatever. And many people were afraid to be truthful because if their partner was going to kill them or had them terrorized, they felt not being truthful about the substance use was the smarter thing to do. And so they would say, no, 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 and get in. But someone who might have tried recovery or had gotten that value of from the treatment field of being honest might have said, yes, I did drink within the last XY number of hours or whatever, and they would be declined admittance. Whereas the person who was open and honest might have been willing and felt safe enough to ask for help. A person who had to hide their drinking or drug use would then feel compelled once in the program to keep it on the down low, not tell anyone, and that's where a lot of problems would brew because by keeping it secret and not talking about it and not feeling safe enough to disclose it, then what happened would be that stuff would come in or things would be done in secrecy, and then something would blow up later down the road. So these are just things to be thinking about. When we are talking about treatment, another value that's common is that more therapeutic perspective, which I talked about is opposite to what would be a more grassroots perspective of the battered women's movement or the sexual assault field. And so what you would hear from treatment providers in many cases is that both peer and evidence-based programming is essential. And they too believe that it should be rooted in the experience of those who suffer and those who provide treatment as well as research. So these are things that you want to be aware of when you're looking at how the fields are organized and many of the common beliefs of both of the fields. Does anyone have any questions or comments? All right. So in terms of treatment, a lot of times if you're not familiar with alcohol and other drug treatment, a lot of times we think you go to treatment, you get fixed, it's like a cake that gets baked, you come out, you're all done. And that I think people outside the field tend to think of treatment as fairly straightforward and one way, one-dimensional. You just go in there and you get fixed, and don't necessarily recognize that it's comprised of more than one model. There's many, many models of treatment. Some models are based on a disease model or a medical, it's a medical form of treatment. Some is behavioral. There are social treatment models, gender-responsive treatment models, developmental models. There are a series of various models. And if you are working in the domestic violence, sexual assault arena, it's very helpful to know the differences. And I find that in many cases, certainly not all, but in many cases, if you're working with women, it is extremely helpful for many women to get services from a gender-responsive program. An example of a good program, there are many in the country, but I just want to mention Residence 12 out of the Seattle area. They do a really good job at developing services that look at the totality of a woman's life. The services, when we're talking about treatment, they occur in a lot of different settings. They're not just various models. We have hospital-based programs, short and long-term residential programs, and in- and outpatient programs. And even the in- and outpatient programs, for example, outpatient, you will find that some people are getting straight outpatient and other people are getting intensive outpatient. And I know from work that I did in Seattle that when we were pairing up advocates and substance abuse professionals, and when programs were developed, such as at the time it was Eastside Domestic Violence, My Friend's Place, today it's called LifeWire out of the Eastside. At the time that program was developed, the advocates and the substance abuse professionals paired up to provide intensive outpatient services. What they soon discovered, and I have found this to be true in a number of projects around the country, was that people in current danger and people that are experiencing intensive outpatient, the combined needs to address both issues were often challenging when it was intensive outpatient, that actually paired work when they were doing integrative services seemed to be more effective if it was straightforward outpatient that required a little less time. What you find when you are putting alcohol and other drug issues and domestic violence and sexual assault issues together to address for one person, the more problems that you're facing, the longer it takes to do half as much. And it is, so we found that going to a longer transitional housing model and combining it with an outpatient as opposed to an intensive outpatient model was very, very effective. So this is things that I wanted to share with you. And the other thing is that substance abuse is treatment, because the illness, because the condition can be chronic and relapsing, it may need to be repeated. And I think that if you work in the domestic violence and sexual assault sector, you also know that people often don't seek assistance just one time, or they may choose to go to shelter repeatedly, that it is, again, a process. And one thing that would be helpful for you, if those of you that are working in the domestic violence sexual assault arena, would be to get more familiar with concept of treatment and recovery and recognizing that they're different, because treatment is limited. It may involve pre-treatment services or harm reduction, as I mentioned first, and pre-treatment, then actual treatment, aftercare, family counseling, and but recovery is a lifelong process. So these are things to be aware of. For those of you that are interested, you can go online and seek or purchase a book on ASAM criteria that will give you some baseline ideas of how people determine where someone is on the treatment scale and what kind of assistance they'll benefit from the most in most cases. Okay? Any questions before I move forward? All right. Now it's a little bit dry, but I'm really happy to be able to talk to you about it, because I've done a lot of thinking on this, having worked in both settings. And there are so many priorities that overlap and things that are different. It helps so much when you're aware of what's going on either side of the street. So when we're talking about, I mentioned pre-treatment, aftercare, Treatment is multidimensional, and not only do we have harm reduction methods and pharmacological support like methadone, but there's the same model that you get in domestic violence and sexual assault. There's one-on-one and group counseling, and for the individual, there's also generally in most programs a family component, and peer support is often encouraged. And recovery, again, as I said, can take weeks, months, years, and it's described as a gift, a state of mind. And one of the most important things to be aware of when you're working with someone who's in recovery is generally they're affected by physically, emotionally, mentally, socially, spiritually, and any component of life. Their substance use disorder is going to affect that in some way. So just to be aware that it affects the person in all aspects that it is to be human. I would say that's true in the domestic violence and sexual assault arena as well. So this is really interesting. I was thinking about this. If you are, whether you're from the domestic violence, sexual assault arena, or even from the substance abuse field, it might be interesting to look at some of the early books that came out about the fields. And certainly when we're talking about substance abuse, so Walter White's book, I believe it's Slaying of the Dragon, something like that, it talks about the development of substance abuse as a peer treatment. Before it was treatment, it began as a peer model. And it's excellent for taking a look at. And when you read that book about substance abuse, if you're from the domestic violence sector, one thing that you find out is how similar our fields are, and it's just that alcohol and other drugs got more support quicker than those providing services for battered women and other survivors and their children, and in the sexual assault arena. So when you look at both sexual assault and domestic violence and substance abuse together, what you see is that for sexual assault and DV, the whole field is rooted in the experience of survivors. Substance abuse, the same. The field began rooted in the experience of people experiencing a substance use disorder. And another common factor that both fields share is a lack of trust in other systems due to system failure to support the needs of survivors or sufferers of substance use. A lot of problems due to lack of understanding, a lot of labeling, a lot of rejection, a lot of blaming. Both fields experience that and stigma. Both fields started out through the development of peer support and self-help models to address the poor system response to survivors or to those experiencing the substance use disorder. And both fields, those people that are experiencing domestic violence and sexual assault, as well as that experience a substance use disorder, they tend to experience trauma, blame, and stigma. This is really common. And this is why when you get through the initial differences in the field and actually get to know each other better, you find out that you have a lot more in common than you ever dreamed. Even though the fields are different, there are a lot of similarities. When we are looking at some more similarities, for me, I think of in domestic violence or in sexual assault cases, people are often terrified because ending a relationship with a partner can be lethal. And for those of us that also work in substance abuse treatment, we know that ending a relationship with substance can be lethal as well. Withdrawal can be lethal. And I think that most people that I've worked with who experience the substance use disorder, they don't describe the substance like an object or a thing. They talk about it in the context of relationship. And I give you an example of this just so you could see how similar it was. A woman came into our drop-in support group for women experiencing both domestic violence and sexual assault, along with substance use. A couple of the women who were members of that group that was based at our community advocacy program for survivors of domestic violence in Seattle, a couple of that women also attended an AA meeting, and they heard her story, and they brought her to our group that looked at both issues. And when she came in, she said, I don't know why these women asked me to come in. And so the group said, well, tell us your story. And what she told us was that she had about 14 years clean and sober, worked a 12-step program. Her husband, at the time that she got into recovery with her, and their marriage lasted. They got sober together, they went through treatment together, and they were participating in AA. And so that's unusual, because a lot of times marriages don't work out when one partner gets into recovery. And even though he was in recovery, he developed a liver disease from the alcohol abuse, and ultimately he lost his life due to that liver disorder. And she was able to stay sober the whole, get through the funeral, the wake, get through all of the first year or two of grieving, and at about the 3-year mark, maybe 3 or 4 year mark, she began to date a guy in the program, in the AA program. And what happened was she started having a series of nightmares. Now, she told us her, quote, drug of choice, her words, not mine. My drug of choice, she said, was Jack Daniels. And she said that the dream she was having was that every night she was going to bed and dreaming that she was sleeping with a 6-foot bottle of Jack Daniels that she was in a relationship with. Now, I tell you this because when a person is in recovery and experiencing long-term recovery, they will tell you what their drug of choice is, and they know that that drug of choice can kill them. That's how they perceive it, as something that will kill me. When you're in recovery, that's not an uncommon belief. And so when she told the group that she was dreaming she was sleeping with a 6-foot bottle of Jack Daniels and had just gotten into a new relationship, the women in recovery who were also survivors of domestic violence, they felt a little alarm go off. And that is why they asked her to come to our support group. And so we talked to her about her relationship, and she shared that, it was pretty good most of the time. There hadn't been any physical violence, but he was making her feel bad. She kind of felt put down, but she thought he was in earlier recovery than her, and maybe he was just not quite, maybe he just was irritable. But the women said, well, emotional abuse can be hard. A lot of women tell us it's harder on them than a physical assault, and that it can leave long-term harm and make you feel very bad. And she said, well, I'll come back if it ever becomes a physical, though. I'm not too worried about this. I'm sad to tell you that within a couple of weeks, this person who had just done a little bit of emotional abuse put her in a coma, and she wound up in a hospital in Seattle. And thank God she was able to recover, and she came back. And she sat down and she said the words that I never forgot. She said, well, I should have figured it out. I had an unsafe relationship with Jack Daniels, and when I started the new one and saw myself in that dream sleeping with a 6-foot bottle of Jack Daniels, I should have realized it was a message that the new relationship was every bit as dangerous as the bottle. And these are the kinds of things that survivors that experience both domestic violence and a substance use disorder, these are the kinds of things that they talk about and share, and ways they can really do a better job safety planning, and ways that they can really have a better understanding of what they're going through. If you get one or the other of these things, it's not hard to draw parallels. So if you're strong in recovery, it's not hard to figure out how to stay safe in an abusive situation. And if you are well informed of how to stay safe and what you have to do to stay safe, in an abusive situation, it makes it easier sometimes for people to be able to take the steps they need to get into recovery. So these are things I want you to be thinking about. Now, another similarity between the fields is that, no surprise, that you don't choose the experience of sexual assault or domestic violence, and you don't choose to develop a substance use disorder. None of us have worked with people that said, I want to grow up to be a battered woman or a survivor of a sexual assault or a survivor of domestic violence, regardless of gender. And nobody that we worked in the substance abuse field said, I was hoping to become a junkie, I really was dying to become an alcohol addict, or, or someone experiencing a substance use disorder. That's not been our experience. Our experience has been, it's like this guy I had for a teacher in Seattle. He told me, if you take a frog and drop a frog in boiling water, it'll hop right out and you'll never see it again. But if you take the same frog and put it in a pan of cool water and turn the jet up bit by bit, the frog can boil to death. And as you know, many of the people we work with, if they're experiencing domestic violence or harm, it occurs over a period of time gradually and gets worse and worse, and then bang, it is really deadly. And the same is true with addiction. If the first time you had a drink, you developed esophageal varices and were bleeding out of your throat, or you got cardiomyopathy, or you got lost the feelings in your fingers and your feet, or you became malnourished or totaled your car, lost your job, and ended every relationship, if all that happened on the first day that you took a drink or used a substance, you probably wouldn't continue. Just as if someone did really mega harm to you on that first date, probably you wouldn't continue either. But these things are revealed over time, and so in most cases. And so be aware that people don't choose it. They find themselves with this problem. And once this problem exists, then barriers exist to services. And when we're talking about both domestic violence and substance use disorders, we're talking about barriers to services such as shelter, and certainly barriers to services such as treatment, for housing, for legal support, and for children. These are barriers that occur because you can't get treatment on demand, and there isn't always shelter space. And people have to get really creative about how they're going to be able to manage one day at a time, regardless of their situation. Advocacy and treatment provider partnership goals, because we have things I think that are in common, I think that we make a good team for working together, and that it's going to be easier for us to work together when we explore ways to define our relationship as mutually beneficial and entered into by both parties to achieve common goals. There are critical differences between advocacy and treatment, and I don't think there's uniform belief within either field of how to do everything. I mean, within the fields, there isn't a complete consensus on what has to be done to provide the best advocacy or to provide the best treatment. And so within the field, it's not uniform. And when we try to combine essential elements between fields, there may be even less things that we universally agree on. But usually I find if you get right down to brass tacks, people do want to support others, and they people do acknowledge that a substance use disorder can ultimately kill you, that domestic violence and sexual assault can do the same, and that we are better off working together and supporting each other and ironing out our differences than just digging in and saying we need to get sober first or we need to get safe first. I spent the first probably 5 to almost 10 years, I kind of evolved. When I first started, I thought you had to get sober before you could do anything, and I did all that I could to get everybody sober first. It wasn't working, especially when domestic violence and sexual assault was a piece, because as soon as someone tried to get sober, there was no batterer that wanted the person to get sober. If you are sober, you're harder to control. So the batterer or abusive person, the person that hurt you, would do everything they could to undermine your recovery, to maintain the control, and risk for violence actually escalated when you went into treatment. How about that? And then I thought, oh, I'm going to go completely over to the other side, and, you know, I think it's extreme, but okay, we're going to get safe first. Everybody gets safe, and then we can work on sobriety. And what happened was you can't get safe if you stop using, go into full withdrawal. There's a process piece that safety is really critical, but sometimes if you're talking about relationships and a person has two relationships, either relationship can be more abusive or more damaging. And so it turned out, the thing that I learned was the person you're working with generally knows if they're at greatest risk from the person or from the substance. And on different days of the week, the substance may be the greater problem, and on other days of the week, the person who's hurting them may be the greater problem. And that they kind of have to decide. Some people will tell you straight up, I just got sober first and then went and dealt with the DV and the sexual assault issues. Others will tell you, I couldn't go to treatment until I was able to get safe or until I addressed these things. And some people said I couldn't do one or the other. I had to go maybe 2 steps forward down one road, back up a little, deal with them both. But whatever they tell you, it takes twice or more as long to reach their goals because they're challenged by multiple issues. And not being able to get safe is going to affect your recovery, and not being able to get sober is going to affect your safety, either sober or in a harm reduction model or however you define your healing. So these are things to be aware of. And there is no guarantee that if you get safe, sobriety will follow. And there is no guarantee if you get sober that safety will follow. These are kind of hard things to realize because we're often led to believe that if you do this one thing, then everything else falls in line. If you're able to get safe or sober or a little bit of both, it's going to be easier to do the next step and the next step. And so when we're talking about survivor defined or a person in recovery defined, we've got to look at the context of their lives and what's going on. Okay? I wish it was easier than that. It's complicated. But if you're willing to take time and provide supports for people dealing with both of these issues, they are able to get clean and sober. They are able to get safe. They are able to lead quality lives and feel well again. Okay, so I'm going to talk to you about some other goals of advocacy and treatment. I think that both fields really would like more accurate prevalence data to know what's going on. One thing I can tell you is if you're sitting in an alcohol drug treatment program, and some of our other webinars get the overview of substance abuse and domestic violence, get into this in more detail. But if you're sitting in an alcohol drug treatment program, based on the numbers, at least half of the people that you got in there, if they're women, have experienced or could be currently experiencing some kind of physical violence. 74% of the women have experienced some type of sexual abuse or sexual assault, and anywhere from 50 to 90+% have experienced domestic violence at some level. Almost all of the persons in alcohol drug treatment have experienced emotional abuse. Huge numbers have also experienced child abuse. So these are things you want to know. If you're sitting in a substance abuse program, virtually anyone in your program could benefit from having a connection with a domestic violence or sexual assault advocate, particularly as they move forward. When you are working in a domestic violence or sexual assault program, what we know is that the data, when I started working at New Beginnings in 1989, the numbers for recovery, people experiencing a substance use disorder was pretty low. I mean, I think when we were doing those King County reports, I think sometimes it would be as high, some months as like 12% of the people coming through. And the people that were coming through and that were self-identifying as having a substance abuse problem were generally people with long-term recovery. They were the only ones really accessing the program because it was routine to deny access to services for people with substance abuse problems back in the early 80s, and that's something to be thinking about. When we actually, in 1990, I think we started doing a group at midnight in the shelter because so many people that experience domestic violence and sexual abuse, they have trouble sleeping. They can't sleep. They have nightmares. They're hypervigilant, sometimes kind of jumpy. Doesn't necessarily mean they've got full-blown PTSD, although some do. But they're definitely experiencing stress reactions, and so sleeping was a problem. And anyone that works in alcohol drug treatment will tell you that you have disrupted sleep patterns for up to 2 years following cessation of substance use. This is particularly true when we're talking about alcohol and other types of sedative hypnotics like Valium, Xanax, Librium, those kinds of things. And so if you have people that aren't sleeping and they're up, we found that that they were pacing around and that they were really interested and wanted to do, wanted some kind of activity or something to do. And so one of the women, said, why don't you do a support group at night? Because a lot of us are working, or the kids aren't, don't go to bed until, I think the bedtime at the time was like 8:30 or 9. If we could do something late, the kids would be sleeping and we would have something to do. Now, mind you, it's not clinical; it's a shelter program, but maybe we could talk about things since they're not sleeping anyway. So remember, I put up a big sign and it said support group for battered women with alcohol problems. So how many people you think showed up? Like, how about nobody? So I changed it to be a support group for. One of the residents said, why don't you write a support group for coping skills, and then we can talk about alternatives to alcohol, but don't put it on the sign because nobody wants to say they got a problem with alcohol. Mind you, back then in the 80s, it wasn't, most people, if you talked about alcohol or drugs and you knew how much people were actually using, you'd have to ask them to go back then. So they weren't about to respond to that. So I put that sign up, a coping skills group, and that's where the group began, the first group in Washington State, in a shelter for survivors of domestic violence with substance use problems. And that group led to the development of community-based drop-in groups and other groups in our county, but it took time. I finally was able to do a similar group in a treatment program in Washington as well, and you won't be surprised to learn I'm a slow learner, and I put a big sign up at the treatment center. Women, in recovery who are experiencing domestic violence or sexual assault come to the group, and none of them wanted to come to that group. And it was another resident that straightened me out and said, can't you just say relationship? And this is where I learned that people don't like, you think I would have figured it out a lot sooner. Sometimes I wonder how I got anywhere. But people don't like labels. And if you self-identify and are preoccupied with getting your substance use addressed, that is generally your primary issue, and you may be willing to explore domestic violence and sexual assault if you discuss it in the context of your recovery, because that's where your mind is at that moment. And if you are in a domestic violence or sexual assault program and you are talking about substance use, you want to talk about that, not like, oh, just get clean and sober, but you want to talk about how that substance use is affecting their safety and preventing them from, getting services or meeting their goals or whatever it is that are the risks that stem from drinking and drug use and having an abusive partner. And one of the big risks that I think substance abuse professionals and domestic violence advocates need to be really clearly aware of is how frequently people who are abusive towards their partners really use their partner's substance use as a part of the dynamic of domestic violence and to control them. They will pull their partners out of treatment against medical advice. They will deny them access to services. They won't let them go to a 12-step or any other kind of meeting. They will threaten to report them to the police or force them to carry drugs or force them to use. All those things are elements of domestic violence, elements of undermining recovery, and when substances are used to facilitate a sexual assault, they're also a form of abuse in the sexual assault arena as well. So these are things that when you're looking at why we need to work together and what some of our goals would be to evaluate what are barriers to safety, sobriety, and wellness, and be aware of how substance use is used by abusers to harm, and also how it is used to undermine recovery rates. And I think that both systems would like to evaluate whether their responses to sexual assault, domestic violence, and substance use disorders are working. And I think they work better when we work together. I remember kind of thinking, wow, this is really weird. A few years ago, I read that the average domestic violence victim goes to a shelter 7 times before they're able to escape if they want to. And I read that in another publication, the average person went to alcohol drug treatment 7 times. And then I saw more recent data that had both people going like 9 times to shelter and 9 times to treatment. And it occurred to me that maybe if we work together, we could cut it in half or make it considerably less if we were working on the issues that affected people as human beings, as opposed to siloed individuals dealing with one problem, because the problems are multiple. And so we need ways to measure how effective our interventions are, and we need empirical data to support what survivors affected by substances, what their advocates, what their treatment providers already know, and we need new data too. I'm happy to tell you that we've been working with a hotline, the national hotline, and have done a number of surveys and things, and hopefully we'll be able to release some data that will be helpful for both substance abuse professionals, mental health clinicians, and also for advocates. I think when we are able to get that information out to you, we'll probably do another webinar on that as well. And I think the end result of more accurate research and working together will be improved outcomes as determined by the survivors themselves, okay, and those who are in recovery or trying to get in recovery or actively using, all of which you will need different interventions. So working together, before I go forward, does anyone have anything that they would like?
Patty, we did have a comment in the chat. Someone was talking about that they co-facilitate a DV education group at a substance abuse program, and that many of the women in the group who share the information about abuse don't typically identify as survivors, but they're often identified as codependent or abusers if they use violence to go back. And so they're talking about how it's hard to collect accurate data, and I thought you might have something to say.
Yeah, actually I do, and I think that's a great, I'm really glad whoever brought that up, thank you very much, because this is a huge problem. I managed to work in a number of treatment facilities in the state of Washington, and also do some groups up in Alaska, co-facilitate some groups up there as well on the treatment side, and of course have done groups in battered women and sexual assault programs in Washington and Alaska as well. And this is so common because, yeah, in fact, sometimes when I'm actually doing the work, I'll just say person-centered or, as defined by you, rather than get into the labeling. And I do know that when what I have found in alcohol drug treatment really, really common is that survivors of domestic violence, they're more likely to have been arrested. They're more likely to report having used self-defense tactics and actually getting physical at times. and that they often present, again, I don't want to make general statements saying everybody is alike, but it is not uncommon for women showing up in alcohol drug treatment to say that they're more comfortable with other men, or they don't trust women, or they feel competitive. And frequently the kinds of comments that I hear, again, I don't want to make the universal statements here, but many survivors of domestic violence or sexual assault that come in alcohol drug treatment come in reporting that they're very angry, and they often ask for anger management right away. And they will often make statements like, I'm as tough as them, it takes two to tango, I'm not going to put up with it. And many times, because anger is one of the things in long-term in treatment for many years, if you talk to people that were trained to be alcohol drug counselors, one of the first things you learn, even probably before you get your understanding of physiology and pharmacology, you're told that anger is really dangerous and it can lead you back to using, and it can affect your sobriety, and there's a lot of focus on getting rid of the anger. And what happens is battered women and survivors of sexual assault come in, they report that they're angry, they want anger management so that they can get clean and sober and get on with their lives and stop, what they perceive as aggressive actions. But if you actually talk to them for a little while, you find out that you have a survivor of a person who's experienced domestic violence and sexual assault. And in fact, in order for that person to be able to recover, they don't have to give you all the details of what has happened, but what they have to do is have the anger validated. Because if you just jump from experience of victimization to the anger has to go so I can get clean and sober, and you don't validate what happened and let the person know it's not their fault, and offer them alternative ways of responding when they're hurt that will cause them less grief, or or to at least validate, well, look, you used self-defense. It's probably, yeah, it didn't land you in jail. A lot of cops are not thrilled with. There's a gender bias against women that are using, or not all, by the way. Not all police officers are like that. I actually come from a police family, so I really want to stress that. But to let treatment providers know that we got to validate the anger and not rush people, and not rush rush to the angry place without validating the harm. You have to. This is why screening for domestic violence and sexual assault is so critical. And in fact, one of the upcoming webinars, we haven't scheduled the date, is on screening tools for substance abuse providers to help them identify domestic violence and sexual assault survivors in treatment. We already have a good workshop on screening for advocates that's up at our website, but I think it would be helpful for us to get that screening webinar up so that you can get tools and strategies to address people coming in through treatment that are identifying either as violent themselves or hanging on the label of codependent. One of the things that I have found, and I mean, it's been a process for me too. I think, I started out as a substance abuse provider, and I identified primarily that way. And when I began to work in the domestic violence arena, and began to learn the terminology and began to learn what people are going through, when I would speak about domestic violence, I had a very strong accent. Like, I almost think of myself as bilingual, bicultural now, between substance abuse and DV, but at the front end it wasn't like that. And for me, I used to think everybody was codependent. Now I realize, because I spent how many years? 16 years in the DV program, 12 on a night shift, and then 10 at the coalition. I've come to believe that codependency is a life-saving strategy if you're involved with a batterer, that it'll actually keep you alive, and that we need to do a lot of reframing. And I don't have time to do a lot of the reframing in this particular webinar, but when I talk about screening in the screening webinar and some of the follow-ups, I'm glad you brought this up because I want to talk about the difference between life-saving strategies and codependency, and really clarify that that getting into an abusive relationship is not so much as a bad choice as it is bad luck, and to talk about ways to get safe and to look at, we can always work with people regarding education, information, signs of an abuser, all that, but we don't want to blame victims for having experiencing an abusive relationship any more than we want to blame people in recovery for developing a substance use disorder, because you just don't do it. And it really helps when we work together and reframe things so that we're not lumping experiences together. One of the reasons I had to really rethink codependency and everything, I used to refer, and I still do refer, people to Al-Anon or Nar-Anon, which is a support group. One of them. There's a lot of different groups that are not 12-step based that we refer to too. But I used to refer battered women to them, and in many cases, I used to refer women in recovery who had partners who were using who they were dealing with, or women whose partners were drinking who didn't identify as experiencing DV to Al-Anon, and they might have never experienced any kind of physical assaults. There might have been some verbal abuse and stuff like that, but if a person went into Al-Anon and they didn't and were not given a warning, violence could ensue. I can't tell you how many people I met over the past 20 years who told me the first time they got beat up was incorporating the principles they learned at Al-Anon. I mean, it was heartbreaking for me because, it was a routine referral. I don't make a referral to it now without saying, if you're concerned about your safety, if your partner's made threats, if you've experienced verbal abuse, it's possible the day you begin to detach with love and let that person be responsible for their own behavior, that violence could escalate. And for example, one of the women told me that every time her partner got drunk and passed out, she would call him in sick at work, and she went to her Al-Anon meeting, and they said, you don't want to be an enabler, let him lay on the floor, and let him deal with the fallout at work. And but what he did was beat her up when she didn't wake him up, and when she didn't call his boss, and when she didn't get him out of it. And it's one thing to say that the term enabling can be really punitive if we don't acknowledge that domestic violence offenders are really dangerous. And the thing that we know, according to the AMA, and this is another, I think what a lot of people in treatment field don't necessarily know, but according to the AMA, 74% of men in treatment have threatened or assaulted their partners at some point. So I think that's pretty terrifying, okay? So we got a lot of talking to do about this particular issue. And now what I'd like to do is talk about some of the ways that we can, like the values that are needed for successful work and relationships. So I think if we recognize the benefit of both life experience and research, we're going to do a lot better when we partner together. And that if we are comfortable both with grassroots work and also with trauma-informed approaches, as well as recognizing the role of professional expertise, that if we know our own roles, that we can do a better job. Your role, if you're an advocate, is what? It's to support someone's safety, autonomy, access to justice, access to services, to advocate, to do systems advocacy. And why you want to be talking about substance use is not to deny services or to judge or blame, but why you want to be talking about substances is primarily to see how it's affecting a person's ability to navigate the system, keep safe, how their partner might have harmed them using their substances, what's going to happen if they go to court, if they're under the influence, how can we support them, a whole host of things. And for those of us working in the alcohol drug treatment or behavioral health setting, Why we want to talk about domestic violence and sexual assault is because the experience of trauma stemming from this can undermine recovery. Abusers and batterers may also actually undermine recovery, that additional supports and strategies may be necessary, and that we are going to do much better in our work, in our primary mission, if we establish relationships with people from the opposite side of the street. And Triple Play is an organization in King County that developed brown bag lunches and training opportunities and ways for substance abuse professionals, mental health clinicians, DV and sexual assault advocates, and healthcare people and people from Office of Children's Services, etc., to get together, have brown bag lunches, training, talk to each other, do case scenarios, and begin to look at a person through multiple lenses. Because the person we're seeing isn't, just a person with battering or sexual assault. A human being experiences a wide variety of life events that are going to affect their day-to-day functioning and sense of happiness and safety and trust. So we need to be willing to look at very traditional as well as non-traditional approaches. We need to listen to I've done a lot of work in Alaska and have been blessed to work with people like Rita Blumenstein and people from the Alaska Native Health Consortium who bring in Native traditional ways of healing to address the aftermath of violence as well as harm coming from substance use. And also I've worked with grassroots DBSA programs and more traditional as well as innovative substance abuse people. And it's important to be willing to try whatever works and to be fluid and to be flexible, to be practical, to be defined by the person themselves, whether we're talking about survivor or recovery. The label is not as important as the human being, and sometimes I think we'd be better served just to say the person I'm working with, this is what this person wants. And to understand that historical perspective, that domestic violence and sexual assault and substance use, all these things come within the context of historical trauma. And that's another workshop we should probably be doing soon. Maybe we could get Gwen and Tia and others interested in this topic and Carmen to help us with that. Confidentiality is critical, especially if you're in a rural area, and then the ability to handle feedback, because we're not always going to agree. And then being accountable to each other for the decisions we make and how we work together. I think that's really important. And so we need to understand that advocates tend to do what we call advocacy-based counseling, which is fairly practical, and where the person gets to provide a lot of input and we're providing clarification rather than direction. Many professionals in clinical settings have degrees and certifications, sometimes at a more pronounced, more numbers of people have degrees in these kinds of clinical settings as opposed to advocacy. Yet the ways of learning and the ways of knowledge from both sectors are equally important and valid. To understand that we talk differently, there may be academic terms or pharmacological terms thrown around in substance abuse. Although if you're doing outreach in the substance abuse field, people pretty much look more like advocates, the people doing outreach or needle exchange work or harm reduction work. The advocates are generally more, in a way, even though they're professionals now, many programs are still heavily supported by volunteers, and they have more of a peer approach, although peer work is highly valued in the substance abuse sector. The language, when we're talking about substance use disorders, we're talking about something that is an illness or that is perceived as pathology, and so whereas if you're working in the domestic violence sexual assault sector, we're going to be talking about domestic violence and sexual assault in the context of a crime. Many times it is a crime. Some of the issues that occur, some of the harm that happens from offenders or people who hurt others is not necessarily a crime, but it still causes pain, and that's against human rights. So treatment, so pathology versus crime or unacceptable behavior. Those are some of the differences in approach. In the treatment setting, there is a treatment plan, and in our setting, in the DV setting or sexual assault setting, there is a safety plan. In treatment, people primarily do assessments, which can take, in Washington State, it can take 3 or 4 days. What the assessment looks like is actually mandated in law, and so you have to meet the Washington State Administrative Code and go through certain sectors. It could take you a good solid week to do a full assessment, whereas in domestic violence we're doing risk assessments and lethality assessments, but we're doing them more frequently, often like minimum weekly, and sometimes on a daily basis depending on the, how high the lethality is. And so you're screening and talking to people about what's going on more frequently. The kinds of things, like this is on this page. Thank you for bringing it up. I think it might be Tricia, I'm not sure. But the hot buttons, if you are, like victim blaming versus codependency, we could do a whole workshop on that. And empowerment versus powerlessness. The interesting thing with empowerment versus powerlessness is, the domestic violence sexual assault field really talks about empowerment, and taking back the power. And in substance abuse, not in all programs, but certainly the concept of I'm powerless over substances and my life has become unmanageable is not unusual to hear in a person that's in a recovery framework and working from a recovery framework. And we know that many women, people who are marginalized, people who feel powerless, have a hard time with that concept of powerlessness. And in fact, I'd say even though I've been doing most of my work in substance abuse and DV, the integration of it, when I do the support groups for survivors who also are in recovery or attempting to get into recovery, vice versa, about maybe 70% have found 12-step and other self-help programs very helpful, but about a third couldn't benefit from it. Fortunately, they were able to benefit from being around people who were working at both issues, but they couldn't get into that notion of powerlessness and other terminology. We, for those of you that are familiar with our book, Safety and Sobriety and Real Tools, I think Responding to Multiple Abuse Trauma, I don't know if it's in both books or just one, we did put together ways to navigate the 12 steps when domestic violence is occurring. And, we always clown around. If you're working in the treatment side, we generally don't tell people we're working with that they need to make an amends to a dealer. And so we try to draw the parallel that a person doesn't need to make an amend to an abuser either, that abuse isn't mutual battery. There's generally a principal aggressor, a person who does the primary hurt and who is engaged in maintaining or gaining power and control. So these are the kinds of topics and issues and conversations we have, and I think they're really important. It's been my experience when substance abuse counselors and advocates work together before they start doing services jointly. It's a really good idea to take a few weeks, a few months, as much time as possible to talk about the differences in the field, the differences in language, and really explore what we have in common and what is different. Sometimes in clinical work, opinions are portrayed as objective, whereas advocates are portrayed as biased. Neither is really wrong. It's just a different way of dealing with it. And certainly providing a voice is not neutral. And they're supposed to be biased. So this is something I just want to stress, that we do our work differently. And our beliefs and philosophy tend to be different as well. So, for example, when you're trained as an advocate, you are trained to believe everything that a person tells you. When you are trained as a substance abuse professional, you are trained to believe absolutely nothing anyone tells you until you can get it validated. It's the same, I think, if you're working in Office of Children's Service in many cases. You want to have collateral information, and it's a different way of looking at things. And I've learned, because I work in both fields, and I've worked in, I did training with Child Protective Services for a number of years. I've learned that I can hold conflicting information in my head. I can believe what someone is sharing with me about their experience of pain and sorrow and being overwhelmed and the needs for safety. And at the same time, I can recognize that it's a sign of trauma that a person may not feel safe enough to tell me the truth about their experience, and that it's okay. My job is to help foster trust by being trustworthy and helping that person feel that they can share with me what's going on in their lives as much as possible. So it's complex. And again, I've only got a minute, so I just want to say, and I think I already mentioned that safety and sobriety, there is no easy answer. People get to decide for themselves. But documentation and confidentiality is critical in both fields. In the substance abuse, in the DV sector and sexual assault, we document considerably less because our information can be used by a batterer or offender against the victim. And the other thing that I want to stress is that in substance abuse treatment, and if you listen to my safety planning webinars, you'll find more about this, but there are considerable risks associated with couples and conjoint counseling. It is not recommended once domestic violence is determined. Better that you have a person work independently or with an advocate. If you're working with children, to bring in, have a children's advocate drop by the shelter, drop by the treatment program on a regular basis, or to develop programming where you can do things together would be really helpful, okay? And I would say the other thing that is critical, many people with substance use disorders not only have civil legal issues, they have criminal issues. And but they're also going to need civil assistance. But not everybody who has a person that's abusive is going to want to file for a protection order. And in fact, in certain cases, while they can be protective for many, they can escalate risk for some. So you don't want to promote that wholesale and assume the person doesn't want to get safe if they don't want to get the order. People working in shelters, unless they partner up with substance abuse people or peer recovery people, may find group living concerns become very challenging if advocates don't have supportive people to help them identify what should, how they can support recovering women, and it just goes on and on. So I imagine that we'll have an opportunity to talk about more of this stuff. The thing that's most important is to assume goodwill, to make friends, to realize it's okay if some stuff is non-negotiable. The whole thing takes time. It's a process. Shortcuts don't work. Find out what you both need and be willing to make it work. And realize that there are no two programs, no two communities, no two people, no two states that do it all alike. And you're going to have to work together to figure out policies, plans, how you're going to train, how you're going to do service delivery, and how you're going to evaluate what you're doing. It's a roller coaster, but let me tell you, when you see people able to get safe, sober, to see their children get healthy, to feel better about themselves, to be safe, you know you're doing the right thing, and that's what it's all about. You see people getting safe and into recovery, and you're part of the process. You can be proud of yourself and go home at night and say, God darn it, I'm a pretty good advocate. And if you're a substance abuse professional, I'm a pretty good counselor because I'm willing to work with others. Thank you so much for your time.
Excellent. Thank you so much. I'd like to thank Patti Bland for such an exceptional webinar. Thank you to Caption Colorado for providing today's captioning, and thank you to Jen Curley for making the webinar run smoothly. Last but not least, thank you all for spending your time with the Center. Within the next week, I will send you all a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts and previous webinars that Patti referenced, all of which will be available on our website. You'll also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, that would be greatly appreciated. Thank you all again, and I hope you have a great afternoon. Take care.